Great. Well, on behalf of my co-moderator, John Messenger, I'd like to welcome everybody to not only this session, but an amazing meeting that continues to grow by the day, it seems. We have more people here today than yesterday. So this session will focus on saves of the year. So each of the presenters will talk about their best save, and then we have plenty of time for discussions and questions as well. So to start off with, Rajiv Gulati will have our first presentation.
Thank you so much. As with most saves, they tend to result directly from errors. This is, hands up, 100% my error of cognition and choice. 76-year-old male, comes with unstable angina, recurrently, background, actually 2 prior stenotomies for bypass grafting. His lemur was not usable. He had a motor vehicle accident as a child and scarred that region, so the lemur was never usable. Had a reamer to the right and a vein to the LAD, mostly diagonal and septals, and from that vein a Y free radial graft sequentially to 3 OMs, a big territory. So that's his anatomy. He'd had over the years a few stents to the proximal and body aspect of that vein graft, that Y graft, and they'd been durable. They'd stuck around and worked very well. But over the preceding, I would say, 6 to 12 months, he's had multiple PCIs around the bifurcation of the vein and that Y radial graft. A few balloons for restenosis, etc. Sort of accelerating interventions around that region. His EF had maintained at 50%. So there's a native left coronary artery, circus occluded, LADs occluded. This is the reamer to the distal right, and the very distal right, the PDA is occluded mostly, so not much of a runoff from this reamer graft. And here's the main graft. You'll see some stents. This is the main graft into the LAD, supplying a big septal, retrogradely going to some PDAs, a diagonal. The LAD itself is minimally filling at the apex over there. And what I want you to see is that Y graft coming off the distal end of the vein. That supplies a huge area of the lateral wall, so 3 obtuse marginals. You see the Y graft coming around. So here's a closer up view. Here we do have this is the region in question, it's the bifurcation. This is that radial graft that's going to multiple OMs. Okay, so 50% EF. The plan is to treat this bifurcation. I think it's effectively the last remaining vessel. That distal right from the reamer wasn't really supplying much, and the EF is 50%. So I'm going to turn to the panelists here. John, impeller? Balloon pump?
Yeah, I think you're going to be working through a single conduit to most of the viable myocardium, okay. So I think it's something certainly that I would consider an impeller for. Is in-stent restenosis, it looks like in the radial limb as well?
Yeah, that's actually would you believe, a bare metal stent in the radial limb, and a drug-eluting stent in the going across there. And they've been ballooned a few times elsewhere. So a quick show of hands, impeller, balloon pump, none. So yeah, okay. Maurizio's none, note that. So we did an impeller, for what it's worth, and this was one of the quickest interventions you can possibly imagine. We thought it might be tricky getting around into that graft, but it was 5 minutes is not an exaggeration. This went smoothly as you could imagine. It was a two-stent crush. The main branch was treated from the body here into the radial, which is treated as the main branch, and here's another stent crushed into the side branch vein. Final kiss, and a good result. Didn't need the impeller. Things went very smoothly, no issues at all. So he comes back at 1 year with 2 weeks of recurrent unstable angina. So he got a year out of that intervention. ECG looks the same, and the EF remains the same at 50%. And the cath shows that radial graft is now totally occluded at its origin. That was probably the biggest territory here. But as ECG's unchanged, the EF's unchanged, so something doesn't quite fit. So it turns out that the native circ was never probably totally occluded. There was always a microchannel that now is apparent. So you have a long, heavily diffuse diseased area of the circumflex that is supplying that vessel wall. So we could think about redoing the graft, or I think most of you would probably agree we should go for the native here. Seeing some nods at the front here. Okay, John, I'm going to pick on you. Impeller, balloon pump, or none?
I probably would not use an impeller in this case. I mean, working on the native, but You know, the challenge is if you end up converting and going back and going antegrade back through the graft, then you compromise both limbs again. So I think if you're going to convert and work on the vein graft again, you'd at least be thinking in the background access for an impella.
Well, some of this was swayed by the fact that he really didn't need it the year before, and, you know, it was so straightforward, he tolerated the ischemia. So we went with what you said, which was none. So this is an antegrade guide. His right radial is occluded. The left radial was used as that graft, remember. So this is a transfemoral guide. This, I believe, was a field XTR. This was one of maybe 10 wires trying to cross this lesion, always getting stuck at the same point there, trying parallel wires, microcatheters. Believed we were in the true lumen, just not able to get a wire across. So I thought to myself, here's one of this, is probably my second error so far. I thought this was a super tight spot over here. And I thought the wires were gripping in there. I thought, well, if I just tease that open with a 1.2 millimeter balloon, no one will know. It'll just make it a little freer, and we'll be in good shape. So we did that.
One question: why didn't you consider imaging the graft with dual injections and consider at least having a layer of the distal vessel with a retrograde microcatheter going through the distal anatomy?
It's a great thought. So the graft was flush occluded. I showed you a still image of the native circ. Actually, with them moving, and I'll show you next, you do actually see those 3 OMs filling. Yeah, filling antegrade. So it had taken over. So it wasn't a CTO. This was just an old-fashioned, long, heavily diffusely diseased lesion. Yeah, but that's a great question otherwise. So we could see the downstream vessel, I just couldn't access it with the wire. So here's the balloon. Okay, so that was not a good choice. The vessel shut down, and we can no longer see those 3 OMs. VFib, multiple shocks, CPR maintaining things, and during all of this, tried continuously to try and wire and open this. Thought about, knuckling and mini-starring into one of those branches, but really, really struggling here during CPR. So many regrets, of course. No LV support this time, but I'm so glad I found some camaraderie there in John Messenger. Why did I balloon? Blaming the wires, ridiculous things like that. The safe part here, really for the fellows, the safe part is the team. Without the availability of expertise in your team college, your nurses, your techs, you cannot save these patients. So this was proper CPR, people who knew the equipment, knew what to do. So we had everyone there at the right time. And then the revascularization strategy. This time we went for the graft. And a Pro 12, a Corsair to penetrate, and then a Pilot 200 to track. It was a little difficult to get to this point here with the wire, but once the wire reached that point, it just flew down. So I think the occlusion was just in that first 20 to 30 millimeters of the graft. Beyond that, the wire was super free, and followed through, of course, with a Corsair. And this little tough, and then it free and just flew down here. And we injected through the microcatheter to ensure we were in the right spot, ballooned that occlusion, and everything stabilized. So now we've got great flow down the graft, no flow down the native, but great flow down the graft. Patient had stabilized and no further arrhythmias. So a temporary save. Of course, this is unlikely to be a durable response given the history of this graft and multiple interventions. So we continued on. Here, that's the microcatheter, trying to access one of those distal OMs. And here, I'm going to give a heads up to Kashish Goel, our superstar fellow at the time. He wired this nicely retrograde through the area of trouble we were having, accessed the antegrade guide, followed through here with the Caravel microcatheter, I think. And this is now converting to standard CTO. Switch out for a long R350 wire, balloon and stent, and get a good final result. So the lessons, I think, were, I still don't know. I still struggle. I think it's easy when your LV's down and you got complex PCI. I think that sort of makes sense to do your support. But those just in case, I find it really hard to predict when things are going to be needed. And I got it wrong this time, right? I used it when he didn't need it, and I didn't use it when he did. Hard to predict. I do think, I'm increasingly thinking that CTO techniques now are becoming incredibly valuable for getting you out of trouble in non-CTO cases. This was a non-CTO case. So we opened the graft to perfuse and stabilize and went retrograde to treat the native. A lesson for the fellows, always appreciate your team. This is the team that saved the day. Without the CPR, we would not have been able to get through the case. And a lesson to the staff, always appreciate the great fellows. Thanks very much.
One quick question. after you were done,
Yeah.
did you consider closing the graft? Quiet the
Yeah.
graft?
So I texted Aaron Grantham about that because it's the worst thing you want to do is to put a plug in the ground. It just feels intuitively wrong. And Aaron said, if you've got a open graft, perfectly open graft, and great TIMI3 flow, he would close the graft. He says if your graft is pretty diseased, or if you've got diffuse disease in the outflow, he would leave the graft alone. So ultimately, I said, I'm going to leave it alone. But I think that I may come to regret that, but that competitive flow issue I think is a very relevant one. How many people here would have closed the graft? Would you have closed it?
Yeah,
You'd have
so
plugged
we've
it?
gone back and forth, Aaron and
Yeah.
Stefan, and we've all had cases anecdotally that we've shared and
Yeah.
talked about and we've all had individually
Yeah.
cases where the graft has resulted in stent thrombosis, early stent thrombosis
Yeah,
in the native, and I don't think there's any real data to support one way or the other.
yeah.
I just was throwing that out there as a potential
I think
consideration.
it's a great thought. We thought about it, but there was a lot of push not to do it, and just losing that access for the future. All of the usual considerations that you have, but we didn't. But I think it's a great.
I mean, that's
discussion.
one of the potential things that remains an unknown, and I think certainly for the vast majority of people in this room, not something that you should be considering at this point. This is an advanced operator concept, and because there's no consistent answer, I think it's a great thought. But whether we perpetuate it universally is tough right now. I think my other comment would be, and I get this all the time, the degree of hemodynamic support. And it's very frustrating because you get people, it's buying an insurance policy, do we need an insurance policy? Well, all of us have insurance for everything else in our lives. And often that's the issue. And yes, we've got a trial that says you have to have LV dysfunction, but when you've got a large amount of myocardium at risk, whether your EF is 50 or 30 or 70, it probably doesn't matter that much. You get into those technical issues, then regardless of what your EF is, you potentially have the same jeopardy. But I think I would have done exactly what you did with each of those two. Impella up front for the first one, and the second one, I would say, though, I would call that a CTO. That was a functional CTO, and a really great result.
Yeah, and I guess, you did not put the Impella in the second time after all your CPR, which is, I probably would have thought, would have had buyer's remorse.
How can you predict that by inflating 125, you're going to have such an electrical storm and such acute decompensation?
Good points.
But there was a discussion earlier on in the session this morning, in the Impella session this morning, where the audience raised two questions. One is reimbursable, is an Impella use? And there was some pushback from some of the audience members saying that their administrators at the hospital had certain criteria, and those criteria were largely protect two criteria. So patients with a normal EF would potentially, quote unquote, be non-reimbursable, but apparently that myth is wrong because the use of the Impella is not linked to ejection fraction.
Okay.
Based on the NCD, it is linked entirely to MCCs.
Yeah.
And so if we said this guy had two previous cabbages and had a sole remaining conduit, and in your opinion, this was suitable for use of the device, there would be no question about reimbursement or no reimbursement.
Right.
That's valuable
I have
information.
another question really quickly, is when there was this electrical storm and as CPR is going on, any thoughts given to ECMO or support first before you spend time on trying to open it up?
Great thought. In fact, I mentioned the team, but we call the ECMO team. And we have a 30-minute thing for them to show up. And by the time they showed up, we just got the graft open. But absolutely, I think the storm and ECMO go hand in hand. It would have been a great thing to do.
So if you have a regenerative vein graft and a native vessel, which is not ugly looking CTO, and this approach is there that you can go through the vein graft and open the native vessel, would you open the native vessel or work on the graft?
Yes. I think that increasingly now, since I've started doing CTOs, I'm increasingly a believer as we should treat the native first. In fact, a year prior, we probably should have done that and not done the graft. you get accelerating vein interventions. This should have been native till proven otherwise. Yeah, that was one of my 12 errors, I think.
And the good thing is it is a very safe avenue to learn retrograde PCI, because you're not going through the septals, and it's the whole environment and you in this, not in this case when it's the sole remaining conduit, but when you have a patent lima and you're working on a right graft that's down, it's a very nice environment.
I agree.
Super. That was a great case.
Great,
Thank you
thank
very much.